Good evening and welcome. I'm Vanessa Hoffman, Program Coordinator for Research and Education at the Bladder Cancer Advocacy Network, Beacon. Tonight we present Muscle-Invasive Bladder Cancer, the second webinar in our spring series on treating bladder cancer. I'd like to do some quick housekeeping. Look at the left side of your screen for instructions on how to listen in on the webinar. To listen using your phone, take a look at the participants box on the top right of your screen, and in the bottom left of that box, click on the icon with a phone and question mark. If you have technical difficulties, please call WebEx Tech Support. The phone number is on the left side of your screen. If you have a question, you should type it in the Q&A box, which you'll find on the bottom right of your screen. Please type all of your questions in this box, and the speakers will answer as many questions as we have time for at the end of the webinar. Now I would like to introduce our distinguished speakers. First will be Dr. James McKiernan. He is the George F. Cahill Professor of Urology and Vice Chairman of the Department of Urology at Columbia University, New York Presbyterian Hospital. He received his BA from Johns Hopkins University, MD degree from Columbia, and completed a urologic surgical oncology fellowship at Memorial Sloan Kettering Cancer Center. Dr. McKiernan is involved in research focused on improving patient clinical outcomes with bladder cancer. He's directed research efforts at Columbia on quality outcomes and effectiveness research on urologic cancer surgery. He is also currently Director of Urologic Medical Student Education at Columbia. Our second speaker is Dr. Douglas Scherr, Associate Professor of Urology, the Ronald Stanton Clinton Scholar in Urology, Clinical Director, Urologic Oncology, Department of Urology at Weill Medical College of Cornell University. He received his BA from Cornell University, MD from the George Washington University Medical School, residency at New York Hospital, Cornell University Medical Center, and fellowship at Memorial Sloan Kettering Cancer Center. Dr. Scherr was the first physician at Cornell to perform a robotic prostatectomy, and he also performs many robotic cystectomies and travels nationally and internationally teaching the procedure to many urologic surgeons. He also sits on several advisory boards in companies involved in urologic technology development. Dr. McKiernan and Dr. Scherr will each speak for approximately 10 to 13 minutes, and then we'll be able to answer questions for about 15 minutes. I will read out the questions, and again, you're welcome to type your questions in that Q&A box as you think of them. So let's get started.
My task tonight is to go over a little bit of a review on radical cystectomy for muscle-invasive bladder cancer, but I also wanted to spend some time talking about a few issues that I think don't get spoken about enough, and that includes the lymph node removal part of the surgery, and then the issue of perioperative chemotherapy, when to use it and what to do when it works very well and what to do when it doesn't work very well, and then also some issues around urinary diversion. So I remember that you said we have about 10 to 13 minutes. I'll try to stay on that schedule. Let's see if I can move to the next slide. There we go, great. So we're talking tonight mostly about muscle-invasive bladder cancer, which, as some people on the phone may know, that involves tumors that have been penetrated through the muscle wall or beyond into the perivesical or surrounding fat outside the bladder. It also includes tumors that have spread into the surrounding organs, such as the prostate gland in men or the uterus in women, and also includes patients who have spread to the local or regional lymph nodes that may be removed at the time of surgery. So radical cystectomy is really defined in a man by the removal of the prostate gland, the removal of the lower portion of the ureters, which is the tube that connects the kidneys to the bladder, and then, of course, removal of the bladder with the surrounding lymph nodes. In a woman, this also includes the removal of the uterus and a portion of the anterior vaginal wall if the uterus is still in place, and then the bladder and the surrounding lymph nodes. And the operation, depending on how it's done in the hospital, will take somewhere between 2 to 2.5 hours, and then is followed by reconstruction or creation of what's called a urinary diversion. And most commonly, patients will stay in the hospital somewhere between 5 to 7 days with some variability depending on whether or not there are any complications following surgery. During the operation, the surgeon will usually sample the areas around the edges of the bladder, including the urethra, which is the outflow tract from the bladder, and then the ureters, to make sure that there's no cancer on the edges or the margins of the surgery. This is a major operation. A lot of attention in our field has been paid to managing the outcomes after this operation, and particularly avoiding complications. And this is because there is a high complication rate associated with the surgery, which will vary widely by surgeon, hospital, or even region of the country. And some of the complications can include problems with the intestines, the heart, blood clots, or infections. And in fact, the readmission rate, the chances of a patient having to come back into the hospital in the first 30 days after such major surgery is somewhere between 15 to 20%. During removal of the bladder, one very important part of the operation I think that gets overlooked is removal of the surrounding lymph nodes, and this is frequently referred to as lymphadenectomy or pelvic lymphadenectomy. And it's important to recognize that this operation in many types of cancer is a diagnostic procedure, which means that it only serves to inform the patient and their doctors as to whether the cancer has spread or not spread. But in bladder cancer, the removal of the lymph nodes can actually be therapeutic, in the sense that if cancer has spread to the lymph nodes, removal of those lymph nodes in their entirety can be curative without any further treatment. And even when the lymph nodes do not show any evidence of cancer, there is some evidence to suggest that a thorough removal of the surrounding lymph nodes may improve survival by removing microscopic areas of cancer cells that can't be measured by the pathologist. So the term neoadjuvant or perioperative chemotherapy has become very common in bladder cancer nowadays, and I want to spend a few minutes talking about that because I think it's something that most patients should be aware of when they meet with a doctor to talk about cystectomy. Traditionally, neoadjuvant chemotherapy means chemotherapy that's given prior to some form of definitive intervention, such as surgery. And in the past, it was not used very often in bladder cancer. And a large national study that looked at 7,000 patients in the late 90s and early 2000s found that only about 11% actually received chemotherapy around the time of cystectomy. And what that means is intravenous chemotherapy, not chemotherapy placed in the bladder. The most common chemotherapy used in this situation is MVAC, or methotrexate, vinblastine, adriamycin, and cisplatin, although a different chemotherapy referred to as gemcitabine and cisplatin is frequently substituted, even though there is no clear-cut proof that that's an equivalent type of treatment. And then complete response after chemotherapy prior to cystectomy actually can be seen. And in the next slide, I'll show you some of the results from the largest study that was done testing the concept of chemotherapy prior to surgery. And this was a trial that was published in the New England Journal of Medicine about 10 years ago that showed that 38% of people who received this chemotherapy prior to bladder removal had no cancer in their bladder when their bladder was removed, meaning they're what we would refer to as complete responders to chemotherapy. And the question now today remains, do those patients actually need to have their bladder taken out? And if 38% of people can be cured of this disease by chemotherapy alone, what is the role of surgery in that situation? And that's a difficult to answer question, and these are some of the other questions I think that are really on everyone's mind when it comes to chemotherapy. Is it worth it? Is it worth the side effects? Is it worth even potentially the cost of doing it and the time that it takes to do it? What are the right drugs? Is MVAC the right drug, or is gemcitabine and cisplatin equivalent? Should you do chemotherapy before surgery or after? And what do you do when the chemotherapy works really well? Can you safely not remove the bladder afterwards? And we've tried to look at a few of those things at Columbia, in particular comparing the results of patients who've received gemcitabine and cisplatin versus those who received MVAC. And we saw just a very slight improved trend towards survival with those patients who got MVAC prior to cystectomy. But interestingly, very few centers have seen the 38% complete response rate that I just showed you in the original trial from 2003. And then the other question is, can you do chemotherapy after surgery? And if a patient has their bladder removed entirely and the pathology is unfavorable, can they go through 3 or 4 months of chemotherapy following recovery and is this equivalent? And we looked at this issue in about the last 146, 150 patients, and there doesn't appear to be a difference between the outcome of whether or not you get the chemotherapy prior to surgery or afterwards. And most recently, there's been a lot of attention paid to what we call quality-adjusted life years, meaning does the side effects of chemotherapy actually pay off for the patient, and is it actually worth it? And we did an analysis this year presented at our winter meeting that showed that there is a substantial benefit to adding chemotherapy to surgery. And in fact, that even from a cost-benefit ratio, there's a dramatic benefit when it comes to the added life years that are associated with the extra cost and time that's associated with chemotherapy. And then those patients who completely respond, we have a series of patients at our center who have been observed after neoadjuvant chemotherapy, and surprisingly, they do extremely well with their bladder in place and have equivalent survival to those patients who have their bladder removed. And this slide shows those two groups next to one another after chemotherapy without any cancer in their bladder, one group getting observation, the other group getting bladder removal. So it remains to be proven definitively, but complete response to chemotherapy may afford a patient an opportunity to avoid having their bladder taken out. If your bladder has to be taken out, then a new bladder has to be created, or new means to urinate has to be created. And most ways in the United States, 75 to 80% of patients will undergo what's called an ileal conduit. And we have seen very recently a slight decrease nationally in the use of what's called a neobladder or internal reconstruction. And this may be due to the older age of patients at presentation, the higher stage of their cancers, and in fact even more use of chemotherapy, making patients less eligible to undergo a neobladder. But two of the biggest drivers that determine what type of urinary diversion a patient will undergo is the age of the patient and the experience of the surgeon. And in this slide from a national study, you can see that as patients get older, there's a much smaller chance that they're going to get what's called a continent urinary diversion, which means an internal urinary diversion. And if they go to seek treatment at what's designated as a National Cancer Institute designated cancer center, there's a 5 times higher probability that they'll be counseled to have an internal or neobladder type urinary diversion. So there are definitely some patient features as well as some doctor and medical center features that will influence the type of urinary diversion that's offered. Here's a description of what's going on in the past 20 to 30 years, and you can see in the beginning, in the 1970s, the vast majority of surgeries that were done were actually done as ileal conduits or external urinary diversions. And then as time went on, the incidence of orthotopic or internal urinary diversion increased fairly dramatically. And we may be just seeing in the last 5 to 7 years that plateauing and starting to decrease a little bit as patients get older at the time of the surgery. An ileal conduit is the most common because the ileum, which is an internal portion of the intestine, is the most mobile form of the intestine. It's the easiest to heal, and it's readily available, and the patient can spare a section of it without much difficulty. Usually does not result in any long-term digestive complications. And it's very simple to make. It has a low complication rate after surgery, and it's fairly rapid to make, so the operation tends to be the shortest. And it's the simplest to learn as a surgeon, so it's widely pervasive in terms of teaching it. An internal pouch that is called an Indiana pouch is probably the most complex way of creating a new bladder, and this is a catheterizable form of urinary diversion, and that involves building a new bladder out of the right colon and connecting it to the skin, and for this a patient would have to catheterize periodically for the rest of their life in order to urinate. And then the orthotopic neobladder, or frequently just referred to as neobladder, is a way to build a new bladder internally and connect it to the urinary channel without having to catheterize at the skin or wear an appliance externally. And of the continent urinary diversions, this is the most commonly done today in the United States. All urinary diversions are subject to some complications, including infectious complications, particularly urinary tract infections, metabolic complications that involve urine being absorbed into the body through the intestinal tract, and then hernias, incontinence, and of course some of the side effects of radical cystectomy in general, such as erectile dysfunction and stone formation in the new urinary diversion. So one of the most difficult to answer questions is what patient should be provided with what form of urinary diversion, and how do we match a patient up with the best type of urinary diversion for them. I think most patients have a preconceived notion that an internal neobladder is always a better form of urinary diversion than an external ileal conduit. But in fact, in this study, which was an analysis of all the studies that have ever been done comparing day-to-day quality of life between patients who had either an ileal conduit or a continent urinary diversion, there actually was very little difference in overall day-to-day quality of life depending on whether the urinary diversion was internal or external. So I think this is something that requires a lot of personal one-on-one counseling between the patient and their doctor prior to deciding what form of urinary diversion to select after cystectomy. I'll stop right there and turn the mic back over to Vanessa.
Thank you so much, Dr. McKiernan. Right now, I'm going to turn it over to Dr. Scherr. Let me get his slides up. Okay. All right, you're on.
Okay, hopefully everyone can hear me. Thank you, Dr. McKiernan. That was a great talk, and I think you reviewed very nicely for everyone the sort of approach to patients with muscle-invasive bladder cancer. And what I was hoping to do this evening is briefly go through a minimally invasive technique of radical cystoprostatectomy, which is a robotic approach. And I think if we go to the slide that says robotics beyond the prostate, many of you are probably familiar with the use of robotic surgery in prostate cancer, and I think that's gotten a lot of press over the last decade, and using the robot to take prostates out. But I think there's definitely a use for the robot beyond the prostate, in particular in radical cystectomy. And I think the real question that needs and is currently being answered is, can we achieve equal oncological outcomes? Dr. McKiernan nicely touched upon some of the important surgical tenets of this disease, and this is one of those diseases where surgery matters quite a bit. And so I think the bar is quite high in terms of what standards need to be set with the surgical management of bladder cancer. And so one of the real issues, can robotics achieve some of this? And we know that radical cystectomy is the gold standard for muscle-invasive bladder cancer, and clearly has a role in T1 disease as well. And the quality of surgery, we know, can certainly impact outcome and survival. So if we now look at the slide with all the effect chemotherapy, Dr. McKiernan spoke about the perioperative role of chemotherapy, whether it's given before or after. But the question always becomes, is the effect all chemo-related? And does surgery really impact? If we look at the slide, there are some variables post-cystectomy that clearly matter. If we look at the bottom, we see that surgical margin status and the number of lymph nodes carry with them the greatest prognostic importance to determining how a patient does after surgery. And these are factors that are determined by the surgeon. So it's incredibly important, as we can see here, that the quality of the surgery is a very important feature of how patients do with invasive bladder cancer. In terms of the extent of lymphadenectomy, we know that the number of nodes is an important determinant also of outcome. Node-positive patients, meaning patients with involvement of their lymph nodes with cancer, can enjoy long-term survival. So this is one of those few diseases that even patients with metastatic cancer can be cured through an extensive lymph node dissection. 24% of grossly node-positive patients can survive more than 10 years. And we know that the more lymph nodes removed, this correlates with improved survival. In terms of the extent of lymphadenectomy, I'm not going to spend too much time on this other than to say that an extensive lymph node dissection is important, and this will be come into play in robotic surgery, because some people criticize robotic surgery for not being able to perform an extensive lymph node dissection, but I'll show you some data to the opposite of that. But what's very interesting is that practice patterns vary quite widely across the United States and Europe. And in fact, if you look at some of the data, 40% of cystectomies around this country in the United States have no lymph node dissection at all. So we've seen how important a lymph node dissection is, but the message is clearly not getting out there. And 12.7% of lymph node dissections only have less than 4 nodes being removed. So clearly, not only do you need to do a lymph node dissection, but it should be extensive in nature. If we go to the next slide, we see the survival by the number of lymph nodes removed, and again, pointing to the fact that the more lymph nodes you remove, even if they're negative, correlates with improved survival. We go to the next slide. Again, talking about radical cystectomy, again being the gold standard treatment for muscle-invasive bladder cancer. And if we go to the next slide, minimally invasive bladder cancer surgery. So the one thing about radical cystectomy, it can be a quite morbid procedure. And what I mean by morbid, it is associated with a relatively high complication rate. So I thought this was an area where there's a great room for improvement to try and reduce the operative morbidity of radical cystectomy. And this is where the interest in minimally invasive surgery has been fostered. We go to the next slide. Some of the concerns for robotic cystectomy and minimally invasive surgery in general with this disease is, number one, there's an absence of long-term oncological outcomes. There's an absence of long-term functional outcomes. Some people criticize, as I mentioned, that you can only do a limited lymph node dissection robotically. Some people argue it takes a longer period of time. And in our cost-conscious world, we're seeing that it also can be more costly to perform a robotic cystectomy. So if we go to the next slide, what are some of the outcome measures of minimally invasive surgery? Well, mostly people have looked at blood loss, operative time, analgesic requirements, time to regular diet, the length of the hospital stay. But what you see is lacking here is oncological outcomes, meaning how do these patients do from a survivability and recurrence standpoint. So we went off in terms to perform a comparison of surgical techniques. And what we did at our institution is directly compare open versus robotic cystectomy, predominantly focusing on early oncological parameters, in particular lymph node yields and margin status. So if we go to the next slide, we did a study comparison comparing the perioperative and early oncological outcomes of open and robotic cystectomy at our institution. And if we look at the next slide, the methods at New York Presbyterian Hospital, between a 2-year period of 2006 to 2008, about 5 years ago, we looked at 88 consecutive patients who had undergone a radical cystectomy by me at an institution. And we compared 21 open cases to 67 robotic cases during this time interval. And I just wanted to touch upon now, if we pass through the next 2 slides, under data collection and analysis. The data was collected prospectively, meaning we collected the data as we went along these patients. It wasn't a retrospective analysis. And we looked at patient characteristics, perioperative outcomes, and early pathological outcomes, and we did some statistical analysis on this data. And what we find was, in the results, that there was no difference in the following parameters among the 2 groups. Number one, they were similarly matched in age, body mass index, ASA class, which is an indication of how sick the patients are, so they're equally healthy or equally sick in each group. The same number of patients had prior abdominal surgery, prior radiation, and the same number of patients in each group had prior chemotherapy prior to the surgery. And if we look at the next slide under the clinical staging of these patients, there was no differences between the staging, meaning that in terms of patients who had higher than stage 2 versus lower than stage 2, the same number of percentages were seen in each group. So they were fairly well-matched groups of patients. If we look at the type of urinary diversions, about 50 to 60% in each group had ileal conduits. As Dr. McKiernan had mentioned earlier, this is clearly the most common urinary diversion done in bladder cancer patients. In the open group, about 24% had an Indiana pouch and 9% in the robotic group. And in terms of neobladders, about 25 to 30% in each group had an orthotopic neobladder. So again, both relatively well-matched groups of patients. In terms of operative time, overall, the robotic group was about an hour longer than the open group. But if you look at the numbers here, that's predominantly because of the neobladders. And clearly, neobladders take a lot longer to do robotically than open surgery. But if you look at ileal conduits and Indiana pouches, there was no difference in the time of surgeries between the 2 groups. Go to the next slide for the learning curve. If we look at the first 10 versus the last 10 cases, there wasn't a significant difference either in the time, so I think the learning curve is not terribly steep in someone who's already had a fairly robust experience in robotic prostatectomy. In terms of blood loss and postoperative parameters, This is where we see a significant difference. The robotic group, the average blood loss was 350 cc's as compared to 750 cc's in the open group. Blood transfusions were less in the robotic group. The mean time to regular diet was on average 4 days in the robotic group and 5 days in the open. And the length of stay, which was dramatic, is there was an average length of stay of 5 days in the robotic group and 8 days in the open group. In terms of postoperative complications, there was overall about the same number of complications, but the major issue is when major complications, which are things that require surgery to fix or return to the operating room, there was a significant reduction in major complications in the robotic group as compared to the open group. If we look at pathologic stage, there was no significant difference in the amount of patients who were organ-confined disease versus non-organ-confined disease. And then the next slide, if we look at node and margin status, we see that the number of patients with negative lymph nodes was about 80% in the robotic group, 57% in the open group. It's just an indication of the likely higher stage disease in the open as compared to the robotic group. But in terms of the lymph node yield, they were basically identical in both groups, about 18 to 19 lymph nodes in each group. And the positive margin rate was not statistically significant difference, only 2 patients in each group that had a positive margin. So if we look at the conclusions of robotic cystectomy, there is a slightly longer operative time, but if you take out the neobladder cohort, the times are about the same. There was no significant difference in time in terms of the learning curve. If you go to the next slide, we did see a decrease in blood loss, decrease in transfusion requirement. There was a shorter time to regular diet, and a significantly decrease in the hospital stay. Next slide, for conclusions of robotic cystectomy under oncological outcomes, we see that the lymph node yield in each group was equivalent, the margin status was equivalent, and now we're beginning to gather long-term oncological and functional outcomes that we're beginning to look at. So I think an important point here, minimally invasive surgery does not equate to cancer-sparing surgery. We've now done over 350 robotic cystectomies, and we're beginning to collect the long-term oncological data. So I will say that, open radical cystectomy is probably still considered the gold standard, but I think what we're seeing now as the data begins to mature, that we can achieve equal oncological outcomes to robotic surgery as well with a much less invasive and less morbid operation. So thank you, and I guess we could entertain a few questions now.
All right, thank you so much, Dr. Scherr and Dr. McKiernan. Now we'll open it up for questions. I see a few people have already typed in their questions in that Q&A box in the bottom right. If you have some, please don't hesitate to type in your questions. For the first question, this person who's writing in says that he has stage 2 highly invasive bladder cancer, had a partial cystectomy, and after 2 years, what are the chances of the cancer returning? Dr. McKiernan, would you like to start with that one?
Sure. Well, that's a good question, a good point. We didn't talk tonight about partial cystectomy, which is essentially defined as removing just a section of the bladder and then reconstructing the bladder in place. This is an option for patients with a very focal, limited muscle-invasive cancer without any abnormality in the remaining portion of the bladder, and it's a unique population because they have to be monitored very carefully to make sure that another tumor doesn't form in their bladder, which is something that cannot happen if a patient has the total cystectomy. But the good news is if you've gone 2 years and you've been checked thoroughly and the cancer has not reappeared, from that point onward, your chances of having another cancer are actually fairly low. So you're just about out of the woods. You still have to be monitored for forever, but after the first 2 years, if there's no sign of recurrence, then you're in good shape.
All right. Thanks so much. The next question, what are the minimum number of lymph nodes that should be removed during cystectomy? Dr. Scherr, would you like to take this one on?
Sure. I think this has been looked at quite extensively. I think in some of the expert panels, both in Europe and the United States, most people would put down as about 10 to 12 lymph nodes as being a minimum number, which is indicative of adequate surgery. Having said that, every individual varies in the number of lymph nodes they have, and I think if you're really going to do an extensive lymph node dissection in patients, most of the time you'll be getting between 20 and 40 lymph nodes that are removed. There are certainly groups that go up as high to the mid-abdomen in terms of lymph node dissection. There are other groups that do more of a pelvic extensive lymph node dissection. So I don't think there's any set number, but I think as a metric, most groups will say between 10 and 12 would be considered a minimum number of lymph nodes that equates with adequate surgery.
Okay. For the next question, does the type of urinary diversion after a radical cystectomy have any effect on the statistics for recurrence of bladder cancer? Dr. McKiernan, can you address this?
That's actually a great question. It's a complicated one because if you were to look at that from a distance, it might appear that it does. And what I mean by that is patients who have an ileal conduit might actually appear to have a higher relapse rate. But the reason for that is that patients who have more advanced cancers are more likely from the get-go to be counseled towards an ileal conduit. And when you look at this independently of their cancer stage, there does not appear to be a direct impact. So there shouldn't be a concern for a patient who has a continent urinary diversion to think that that might increase their incidence of cancer coming back again. But if you look at the entire country, patients who have ileal conduits probably have a slightly higher relapse rate, driven predominantly by the fact that their cancers were worse to begin with.
Okay. For the next question, what percentage of patients require hernia repair after cystectomy? Is there a difference in open versus robotic cystectomy concerning the development of hernias? Dr. Scherr, can you take this one on?
I think after any kind of abdominal surgery, whether it be laparoscopic or open surgery, there is obviously a slightly higher hernia. Now, hernias need to be distinguished between two types. There are ventral hernias, or what we sometimes refer to as incisional hernias, and then there are inguinal hernias, which are hernias that occur in the groin. If you look at the data with laparoscopic pelvic surgery, and most of this comes from the laparoscopic or robotic prostate data, there is a higher incidence, about an 8 to 10% increased risk of an inguinal hernia, a groin hernia, after that form of laparoscopic surgery. Following robotic or open cystectomy, keep in mind when we do this surgery robotically, we still have to make a small midline incision to extract the specimen, and so there is still the risk that someone can develop a ventral or incisional hernia in that location, which is probably not too different from what you would see in the open series. So I would venture to guess, and again, I've not seen any data comparing the two as it relates to this specific question, but there's probably not a huge difference in the risk of developing ventral or incisional hernias, but there may be a slightly higher risk of inguinal hernias due to the laparoscopic approach.
All right. Thank you. For the next question, how effective is chemotherapy and radiation versus radical cystectomy in terms of survival? Dr. McKiernan, can you start with this one?
Sure. Yeah, that's actually a great question. Also, we didn't discuss that much tonight, but for patients who either do not feel comfortable having a major surgery or those who have significant cardiac or pulmonary problems that would prevent them from undergoing general anesthesia, the combination of systemic chemotherapy and external beam radiation has been used. And there's never been a well-designed, what we call randomized study, where you have somewhat equal numbers and equal types of patients in each category to compare those two treatments head-to-head. In general, the efficacy is in what we call retrospective or backwards-looking comparisons between groups that are slightly different, and you tend to see a slightly lower cure rate with chemotherapy plus radiation when you compare it to upfront complete surgery. In addition, some patients who receive radiation therapy for their bladder will be cured of their cancer, but the side effects of the radiation may actually make the bladder less functional and eventually result in the need for urinary diversion because of difficulty with the function of the bladder.
All right. Thanks so much. And I guess everyone can see on the slides that our next webinar will be going into bladder preservation therapy and talking more about chemoradiation. For the next question, what is the difference in recovery time and hospital stay between a radical cystectomy and a partial cystectomy? Dr. Scherr, can you address this?
Yeah, I think the difference between a partial cystectomy and a radical cystectomy is really significant in terms of their differences. A partial cystectomy, the major advantage of that is you're spared the urinary diversion. And the urinary diversion is, as Dr. McKiernan pointed out earlier, either an ileal conduit, an Indiana pouch, or a orthotopic neobladder, all of which are made out of the intestine. And anytime you have to operate on the intestine, that's really what sort of determines and dictates your hospital stay and your postoperative course. So I think the recovery from a partial cystectomy, outside of maybe needing a Foley catheter in your bladder for 7 to 10 days after the surgery, the recovery is quite simple. Whereas the recovery after a radical cystectomy, we're talking 6 to 8 weeks at a minimum before someone's really beginning to feel like themselves.
Okay. For the next question, it says, does removing nodes cause any challenge to future filtering or filtration? Dr. McKiernan, can you address this?
Sure. So the lymph nodes that are removed during cystectomy are in the pelvis, which is inside the abdominal cavity. And in general, they can be removed without any long-term side effect to the patient. There are some exceptions to that. For patients who've had either prior lymph node surgery or radiation, you can occasionally experience what's called lymphedema in the lower extremities after extensive removal of abdominal lymph nodes. But that's fairly rare in the typical patient who has not undergone any kind of lymph node surgery or radiation in the past. So the short answer is, in general, you don't miss them, and there's no side effect long-term to not have these particular lymph nodes.
All right. Thank you. For the next question, what is the survival rate for a woman who's had a radical cystectomy with ileal conduit, who had chemotherapy beforehand, if the person had stage 2 muscle-invasive cancer and the lymph nodes were clear? Dr. Scherr, can you address this?
Right, so if you look at the data regarding neoadjuvant chemotherapy, which is what this question is addressing, and this patient has muscle-invasive disease, the pathology is all dictated by what the final bladder looks like after the surgery. So about 38% of patients who receive chemotherapy before surgery and have their bladders removed, about 38% of those patients will have no residual cancer left in their bladder at the time of surgery, and clearly those patients have the longest survival in upwards of 96 to 97%. Then obviously everything else is stage related, so whether it's stage 1, which is into the lamina propria, or stage 2 into the muscle, or into the fat beyond, clearly is what dictates surgery. So it's hard to give a number if we don't know the exact pathology on what the final specimen looks like after the surgery.
Okay. Thank you for taking that one on. For one more question, for Dr. McKiernan, you mentioned in one of your slides that there's been a 50% decline in use of neobladder in some U.S. centers. Can you expand on that a little bit?
Sure. I think that's isolated to certain areas of the country. I wouldn't want to say that that's the norm around the country, but the trend I was trying to elucidate there is that after a fairly rapid expansion of the use of continent diversion throughout the 1980s and 90s, we've seen a little bit of a pulling back nationally because of a few factors, but I think the biggest driving factor is the rising median age of the population. And so it was fairly unusual to perform cystectomy in patients in their 90s 25 years ago, but it's actually not unheard of now. And age is the biggest driving factor in counseling a patient regarding ileal conduit versus internal urinary diversion. So if the average age of the patient undergoing surgery goes up just a few years, then the incidence of internal urinary diversion will decline. And as the United States population ages, with the median life expectancy extensions that we've seen over the past 30 to 40 years, I think it's not surprising that we see a sort of pervasive use of ileal conduit.
All right. Well, I'd like to thank again our speakers, Dr. McKiernan and Dr. Scherr. Thank you so much for presenting tonight. That's all the time we have for questions. Please take a look at the slide. We have 2 more webinars coming up in this spring series on treating bladder cancer. April 11th, bladder preservation therapy, And April 17th, we'll be talking about chemotherapy and bladder cancer. Also, we have the Beacon Walks for Bladder Cancer taking place on May 4th. Please go to the Beacon website or go to walkatbeacon.org if you're interested in getting involved or participating. And again, thank you everyone for joining us, and have a wonderful night.